Good afternoon, everybody. I'm glad that we have everybody still here. I'm going to try to make up for a little bit of, I see that I have 15 minutes to give my talk. It's a little bit longer than that, but I'll try to make up for some time. I thank Dr. Pardo for sort of setting the stage for a little bit about what I'm going to talk about, which is specifically a gynecologic condition, which is one of the most commonly found gynecologic conditions globally, locally, everywhere, which is uterine fibroids. This is going to be an overview of disease and disparities. And just a little bit about myself. I'm by training a urogynecologist and fistula surgeon, so the bulk of my work through my organization, IMR, is abroad teaching surgeons skills to repair maternal birth damage in the form of obstetric fistula, as well as prolapse and incontinence. But everywhere I've gone in the 5 or 6 different projects we have around the world, one thing I always see, since I care for women exclusively, is uterine fibroids or myomas. So I thought it would be nice to really spend a little bit of time with you guys and talk about that. These are my purpose and objectives. You can read those for yourself, but initially just going over the epidemiology of fibroids, clinical considerations, and ending up with disparities in fibroid care, again, expanding a little bit more on what Dr. Pardo had gone over. The overview of fibroids are also known as myomas and leiomyomata. So all 3 words refer to the same condition. We'll talk a little bit about prevalence, symptoms, diagnosis, and treatment options. What are myomas and how prevalent are they? So the actual definition is that this is a solid neoplasm. So it's a benign tumor that is composed of smooth muscle cells and fibroblasts. They vary in size and the places that they occur in the uterus, and it is the most common benign pelvic tumor in women. Here's a schematic of just where you can find them. Anywhere that you have uterine fibroid tissue or uterine tissue can form a myoma. So they can be submucosal, which is under the endometrial lining. They can be hanging off, pedunculated. Let's see if I can get this. Was there a pointer? Or oh, roller ball. Oh, okay. Yeah, so pedunculated, like a little earring hanging off your earlobe. They can be really inside the uterine cavity. They can grow just under the serosal layer. They can also be found throughout the parametrium after surgery. They can seed after being taken out. And so they're very interesting places where they have been, in case reports, found. And depending on where they are and how big they get, that really does lead to the kind of symptoms that women have. So FACOG, which is our International Federation of Gynecology and Obstetrics, it's our international organization, has a very elaborate sort of classification system. But again, you can see depending on where they grow, where you have smooth muscle that can become a fibroid, can definitely impact the kind of symptoms that people can have. They are very, very common, and we think up to 70% of women globally will have fibroids, but only 25% are symptomatic, so we actually don't really know how many women have fibroids because many can be asymptomatic. Again, largely unknown incidence, but it increases with age, family history, hypertension, diabetes, and some chronic conditions. It's 2 to 3 times higher in Black women, and it occurs in almost 70% of Caucasian women and in greater than 80% of African American women by the age of 50. Black women have earlier onset, more anemia, larger fibroids at the time of diagnosis, and it's been speculated and shown in several studies this is likely to systemic racism and social determinants of health, again speaking to delays in care, lack of access, and racism in our medical delivery system. We have higher rates of hysterectomy and open surgery in African American women who have uterine fibroids, even when it's controlled for the uterine size. And symptoms, there's a wide range of symptoms. You can have bleeding that can be prolonged and heavy with clots, ultimately leading to anemia, in some cases requiring a blood transfusion. There can be a lot of pressure symptoms associated with uterine fibroids. They can get as big as a full-term pregnancy, or stay, again, small, but depending if they press on the bladder, you can have urinary symptoms, you can have a lot of pelvic pressure symptoms, symptoms that affect bowel movements if they're towards the back against the colon and large intestines. And so it can really show up in many different ways. As far as diagnosis, we always start off with the history and examination. So we ask about symptoms, growth. If you've noticed a growth or pressure, people can actually palpate and feel fibroids when they get big enough to pull it up out of the pelvis. Pain, bleeding symptoms are really important. Like I said, you can have abnormal bleeding that can lead to anemia. So testing for anemia and blood counts is part of the workup. And again, imaging. After your physical exam, transvaginal ultrasounds, sonohysterography, hysteroscopy are all different ways that we can diagnose not only uterine myomas, but also find out where they are specifically. And with MRIs, they come into play when we're talking about surgically planning removal of the fibroids. We want to make sure that we also evaluate for other pathologies that could get masked because many times women are dismissed. They say, oh, you just have fibroids, so there must be nothing else really going on explaining your bleeding or your pressure symptoms or your pain. So we have to always be very aware and vigilant in ensuring that it really is these smooth muscle tumors that are causing the condition. And one other thing I just want to bring up is the malignant sarcoma, because at times myomas can be just treated as benign and no high index of suspicion that there could be one that has undergone transition to a malignancy. So here's just an MRI that you can see here of large myomas, and these are all the ball-like structures are the fibroids. And you can see they can get quite large. They can get big enough that they push on the diaphragm, and you can have respiratory symptoms as well. And you can see where they occur and how big they get can really lead to a lot of discomfort and symptoms that women do feel. Here's a pathology specimen postoperatively of a cut section of what these fibroids can look like. And oftentimes, it's not common that you just see an isolated, 8-centimeter myoma that's just sitting at the top of the uterus. Oftentimes, you'll have multiple fibroids. As you can see in this picture here, there's one that's into the cavity, distorting the uterine cavity. There are smaller ones on the outside. And as you know, or if you don't know, gynecologists are definitely obsessed with fruit. So we always talk about ovaries being a certain size, it could be an almond, but we also talk that way about fibroids as well. So we categorize them as small, medium, and large, and yes, again, using fruit as our reference point. A little bit about the leiomyosarcomas. They are a rare malignancy, but can be very deadly if they're just confused and sort of confused as normal myomas that are benign. So this is a leiomyosarcoma that is coming out of the myometrium into the cavity, and it's been opened, and you can see it has an irregular nature, and it's really on the final pathology that it'll be diagnosed as an actual cancer. As far as sarcomas, I'm going to bring it up again because oftentimes they can mimic benign fibroids and are often dismissed as such. They are uncommon, 8% of uterine cancers, but intraoperatively, if a case is being done and being treated as benign, they can spread pretty rapidly. And that's what we've seen a lot more, especially with minimally invasive cases where a patient was told they just had fibroids, but it turned out to be on final pathology that there actually was a cancerous leiomyosarcoma, but by that point, because the surgery had been done, the cancer had already spread intraperitoneally, and once that happens, it's very hard to treat. They can be rapidly growing, so one of the questions we ask also with somebody who presents with uterine myoma or fibroids is, how fast have you noticed the growth? Has it been all of a sudden something has started to grow and you can palpate it? But again, one of the things is it can be really hard to distinguish on the imaging you get. So I think a high index of suspicion is always good as clinicians. So again, this is a leiomyoma or regular fibroid on the left, and then one that is a leiomyosarcoma towards me, which you can see increased mitosis and cellular disarray. And as far as treatment options for fibroids, many times, since many women are asymptomatic, and it could be an incidental finding on an ultrasound for another reason, if patients are asymptomatic, you can do expectant management, which means that we don't offer any treatment, but just keep an eye on it. There's medical management options, complementary and alternative medicine options. There's really a lack of evidence so far for fibroids. And then interventions, which we should always have as patient-centered, shared decision-making, but they're symptom-focused. And again, we have to be aware of a patient's desired fertility because we're talking about the uterus, and a hysterectomy is not always going to be the best option for a patient, nor acceptable. And then surgical options. So expectant management, candidates are women who are asymptomatic. Again, patients who are approaching menopause are also ones who can be candidates because myomas, since they are dependent on hormones like estrogen and progesterone, as you get towards menopause, many of the myomas will decline in size, and symptomatology will also then regress. And how to follow is, on annual exams, just a quick examination, making sure you evaluate your patient for a change in symptoms, and that's adequate. As far as medical options, we want to focus on the symptomatology. Is it pain? Is it excess bleeding? For bleeding treatments, we have medications that we can offer, and GnRH antagonists can be effective for blood loss. Up to 88% of patients will have improvement, but you can only use it for up to 24 months. IUD with hormones can also decrease the amount of bleeding if that's a primary symptom. Combined oral contraceptive pills can be an option. Tranexamic acid can also limit blood loss. And depending on the bleeding and the size, GnRH agonists can also be used. But usually those are used getting ready for surgery to help a patient build up their anemia if they have anemia. And the one that we use for that is injection Lupron. Again, it's bridging until another strategy or intervention. It can decrease blood flow, decrease myoma size, but once you stop the treatment, the actual fibroids can grow back 3 to 9 months after you've stopped the treatment. As far as interventions, we have a fairly large variety. We have uterine artery embolization, radiofrequency, focused ultrasound, and endometrial ablation. I'm just going to quickly go through each one of those. As far as uterine artery embolization, it's recommended as an intervention for uterine preservation. You have embolic agents that are delivered through catheterization in the uterine arteries, but it can cause devascularization and involution of the fibroids, and you can have significant reduction in size for up to 5 years. It does improve bleeding symptoms, but again, there is a high rate of reintervention that may be needed, fibroids that can grow back. And here's just a schematic of what that looks like. You have catheterization through the femoral artery, and then pellets are delivered, obstructing the uterine arteries, which will feed your growing fibroids. There are complications, 1 to 12% of major complications, including unplanned hysterectomies, rehospitalizations, ovarian failure, because again, the uterine arteries, if you're blocking blood supply to them partially, it also can affect ovarian function. You can have minor complications. There is limited data on fertility in the future, but we do know you have increased risk of pregnancy losses, C-sections, and postpartum hemorrhage in women who've undergone uterine artery embolization, but then gone on to have a pregnancy. Radiofrequency ablation was first reported over 20 years ago. It's safe to use, also uterine preserving. It's not commonly used, though. As far as focused ultrasounds, it's using high-intensity ultrasound to cause necrosis. Obviously can be painful, but it's not recommended at this point after small trials were done. Less improvements in symptom of quality of life, and over 50% of women needed some sort of other intervention to help treat their symptoms. There's endometrial ablation that's used for various different things. It's an intervention that actually destroys the endometrial lining. So this would be good for patients who may have bleeding disorders, but there is insufficient evidence to recommend it for treatment of uterine myoma-related bleeding disorders. But what it is essentially a balloon that's kind of put in with heat, and what it does is it destroys the endometrial layer. And we have surgery. Lastly, we have surgery. As a surgeon, I always talk about the surgery, but considerations, again, you're dealing with women at different phases in their life, different life cycles, and fertility considerations are a definite something that we have to consider. Fibroids can cause cavity distortion, as I showed you, the ones that come into the cavity. So surgery that can, if you're thinking about future pregnancies and worried about the endometrium being distorted, removal of those fibroids would be an option. Again, anemia is found very commonly, so preoperative management, if you're considering a myomectomy, which is where we just remove the fibroids, leaving the uterus intact, or hysterectomy, where the entire uterus is removed, and this is definitive therapy. As far as myomectomies, that's where, again, the fibroids are removed. It's a consideration if a woman wants to keep her uterus for whatever reason that may be. It could be fertility, it could be cultural. It's a very personal decision. A myomectomy can be performed hysteroscopically, which is taking a small camera through the cervix into the uterus and removing the fibroids, laparoscopically, which is minimally invasive, robotically, also minimally invasive, or abdominally, where you have an open laparotomy. All of these studies have shown that myomectomies do improve quality of life. It's not 100% clear if it takes care of almost all bleeding issues, and pregnancy rates do differ if it's subserosal versus submucosal. Again, fibroids on the outside don't necessarily distort the cavity as much, so you can imagine those that are submucosal or in the actual uterine cavity, pregnancy rates may be lower. A hysteroscopic myomectomy that I had mentioned is actually where a resectoscope is taken through the cervix, and a submucous fibroid is sitting there distorting the cavity, and it's essentially like a hot knife through butter. It's using cautery to remove fragments of the fibroid that are distorting the cavity. So at times you can't always get the entire fibroid out, and you certainly don't have access to ones that aren't immediately available there in the cavity. It's low risk of complications, though, and low reintervention rates. For the right patient, it's a good option. As far as laparoscopic or robotic myomectomies, it's great for symptomatic treatment and, again, uterine preservation. It's faster recovery time and less post-op pain has been noted. The short-term quality of life is the same as an abdominal myomectomy, which is an open laparotomy myomectomy. But we have studies that show that there's increased rates of recurrence of fibroids if there's greater than 5 that are removed. As far as using the robot, everybody likes to bring up the robot when they talk about surgery. It offers no benefit as far as OR time, blood loss, or hospital stay, but then the surgeons do get to say that they use a robot. That might be the main benefit. As far as hysterectomy, which is actually removal of the entire uterus with the fibroids in situ, it's recommended as definitive solution. Myomas are the leading reason for hysterectomies in this country. Again, if a patient doesn't have any future fertility desires, it may be an option. It can obviously will improve the anemia because you're removing the source of the anemia. There's improved quality of life, and if possible, the vaginal route is preferred just because it's minimally invasive and it has lower complication rates. It's better for the patient. And as primarily vaginal surgeon, I always try to make a push for it if it is possible, because sometimes the uterus may be so big with the myomas, it may be physically incredibly challenging. Again, ultimately, we want to focus on quality of life. The effects of doing myomectomy and hysterectomies do offer improvement in quality of life symptoms, both in long-term and short-term studies. And a little bit on, just going to finish up with health disparities in fibroid and myoma care. Healthy People 2030 from the Department of Health and Human Services defines health disparities as a particular type of health difference that's closely linked with economic, social, or environmental disadvantages, which are the result of the social, structural, and political context. There was a systemic review done a few years ago by Keaton et al., which showed that the prevalence of fibroids are higher in Black women. It's possibly due to an increase in exposures that cause the fibroids. It could be a lack of access to high-quality care, allowing for them to get bigger, and also that there is a higher rate of negative experiences that women Black women that enter the healthcare field for care do experience. Are there biological differences in fibroids? And we do have evidence from 2024, Bateman et al. Did an analysis of microscopic histologic analysis and found that fibroids in Black women compared to white women had a higher incidence of mutations, had increased extracellular matrix proteins, and stiffer phenotypes, that the fibroids themselves were actually firmer. And in the same year, Bariani et al. Found that there was a higher extracellular matrix proteins in the myometrium, or the actual muscle of fibroids in Black women, before the fibroids actually developed, thereby possibly leading to the conversion of normal myometrial tissue to fibroid tissue. So there is evidence to show that there is a difference histologically in Black women and white women's fibroids, which needs to really come into play, because that means that we need to really have a different understanding of how we treat, diagnose, and care for women based on their ethnicity and race. As far as gene expression, we know that the genes expressed by fibroids are impacted by allostatic load. Allostatic load are chronic daily stressors. Racism, sexism, and other marginalizing harmful factors can actually impact the rate of gene expression. We know that hair products, relaxers, straighteners with chemicals are associated with an increased risk of fibroids, and Wise et al. Found that ever versus never use of hair relaxers among Black women was associated with a 17% higher incidence of uterine fibroids. And there is clearly disparities in treatment, and we have a lot of evidence to show this. We know that Black women are more likely to undergo surgical intervention as opposed to other more non-invasive options. There are higher rates of hospitalizations, myomectomies, and hysterectomies when you compare it with white women. The post-operative complications are significantly higher in Black patients compared to white patients, with an odds ratio of 2.5, and this could be because of the rate of interventions and the type of interventions, that they're not necessarily offered the most minimally invasive intervention, which has lower rates of complications, and that's something we know. We know that pre-op blood transfusion rates are also higher. And religious restrictions on transfusion. There was one paper that may have found a role just because more Black patients may be Jehovah's Witnesses, and there's a restriction on transfusions. Also, this could impact and delay the avoidance of medical care, making the fibroids possibly get worse, get bigger. So that could have an impact on transfusion rates as well. And then there was another study in 2010 that reported that a lot of the bigger studies with fibroids actually didn't even report race or ethnicity. As far as the socioeconomic impact and fibroid care, we know white women and women of other racial groups with private insurance are more likely to undergo laparoscopic or minimally invasive procedures, such as the robotic procedure, the laparoscopic procedures. And that African Americans, Hispanics, and women with Medicare coverage are more likely to undergo abdominal procedures, even for the exact same indications when they were put side to side. So if you undergo an abdominal procedure, that's a much more invasive procedure. Hospitalizations are longer. Risk of postoperative complications are higher, including infections, bleeding, and other things that can come after abdominal surgery. As far as the socioeconomic impact and fibroid care, a meta-analysis just earlier this year from Sleemi et al. Reported that non-white patients often demonstrated lower access to minimally invasive surgery utilization and higher rates of surgical morbidity than white patients, and that Black and Hispanic patients were less likely to undergo, again, minimally invasive operations compared to white patients. And again, so this impacts the complication rates, it impacts postoperative complications, intraoperative complications, and non-white patients from the same study had a higher risk of, again, developing surgical complications after hysterectomy, whether or not they underwent a minimally invasive procedure or open hysterectomy. So those are all very interesting findings, again, earlier from January this year. It's well documented that Black women have a 2 to 4 times higher incidence of high-risk cancer types and worse outcomes due to many factors, including high-risk subtypes. So just a little bit about uterine cancer care. I want to just go back to the leiomyosarcoma that I brought up earlier. Factors include access to care, symptoms, and bias in diagnosis. And the incidence of non-endometrial subtypes was higher in Black women compared to white women, with the most pronounced differences seen in serous carcinoma, carcinosarcomas, and leiomyosarcomas, all with pretty less than favorable outcomes. And again, this was in September 2024 from one of our bigger journals, the American Journal of Obstetric Gynecology, which clearly pointed out that the fibroid crisis in Black women, more work needs to be done. Work needs to be done, on an intervention outreach level, on the care that we give, on options that are given to women, and also research, knowing now what we know as far as biological differences. As far as recommendations to consider, again, there are many treatment options. There's expectant management, but also surgical versus medical, depending on what your patient may desire. And the best outcomes occur, again, with patient-centered care, shared decision-making, and culturally competent care, which I think is remarkably important. We know that disparities in care impact on fibroid pathology and diagnosis and care are prevalent, and everything from the microscopic level of gene expression to structural causes that do impact fibroid care. And that's it. Thank you. Do you want us to stay up here?